everyone. This is Lynn Crawford from Hope Dementia Support, and we're here today with Jami Caulley from Providence. Thank you so much for coming across the river, even if it's virtual, to talk to us about home safety and fall prevention, which is such an important topic for us all. Uh, I'm going to have Jami tell you a little bit more about herself, but first of all, I'll remind you to save any questions or just put them in the chat or put them in the Q&A, and we will be sure they're answered before we leave here tonight. So thank you for being here, Jami Caulley.
Thank you. Thank you for having me. Yeah, my name's Jami Caulley. I'm a physical therapist, and I work for Providence in our senior health program, which is a program that doesn't run any clinical operations, but we basically try to help the other clinicians within Providence take better care of older adults. So we develop education and workflows and resources for them to do their job well, taking care of older adults. And I get to do a lot of fall prevention work in that programmatic role. And then I still work as a clinician with Providence at one of our outpatient rehab clinics there by Providence, Portland. I mostly see patients with balance issues, either from inner ear disorders or from neurological reasons, or just honestly, just some of the changes that come with age, some of the comorbidities that pile up and affect people's balance. So I will go ahead and share my screen, and once I do that, I won't see you all very well. So Lynn, interrupt me if like the volume isn't enough or something happens. We can.
Right now, it's perfect.
Okay, great. Okay. And you're seeing my slide, is that correct?
It's perfect.
Great. Okay. So in the handouts that Lynn, I sent to Lynn, and I believe she forwarded to all of you, there is this self-assessment questionnaire for fall risk. This is put together by the CDC. It's part of the STEADY initiative. And we use it at Providence. You may or may not have seen it depending on your healthcare provider, but it's widely used as a way to screen for falls. So I would encourage you, if you didn't get a chance to go through it, to go through and answer yes for both yourself and then also your person that you care for with dementia. You can answer for them or with them. And it helps identify some of the specific risk factors that you might have for fall risk. Overall, a score of 4 or more is increased risk for falls, and a score of 0 to 3 is normal risk. So we say normal risk because there is no risk, right? Everybody has some risk to fall because gravity exists, and some falls will happen regardless of what we do, but many can be prevented. And so I hope today you are able to take away some things that that you can do to help prevent falls for yourself and your loved one. Let's see. One thing I didn't practice was advancing my slide. There it is. Okay. We give these presentations all over wherever Providence has hospitals across the state. It's called Stay Healthy and On Your Feet. And again, a lot of the material that I use here is from the CDC STEADY initiative, as well as the National Council on Aging's Falls Free. You can also, that questionnaire I just showed is available in electronic form from the NCOA Falls Free. And it's kind of a nice way to do it. If you want to do it online, you can share it with somebody, or you can send it to your healthcare provider. There's a way to email it to somebody if you do it through their Falls Free initiative. So in those handouts, you have all of these slides, so you don't need to write this all down. I hope that makes it easier. You also have a home safety booklet that was developed by an OT at the VA. It is specifically meant for caregivers of persons with dementia to help identify risks, specific risks in the home that would be related to their fall risk. You have that self-assessment questionnaire. There's a list of medications that are commonly associated with increased risk, and there are many more that aren't on that list, but those are like the biggest ones. And then there's a steps to reduce fall risk, which is kind of a summary and maybe one that you can share. And then I also included our online exercise resources. We'll talk a lot about exercise today, but knowing that there are many caregivers here, figuring online might be an easier way for you to access some additional exercise, though in person, of course, is always great. So the goals of this talk are just to learn what contributes to falls for all older adults, but then what are the specific things for persons with dementia that are unique or different to consider. And I hope that you can identify some actions that you can take for yourself and your loved one to decrease the risk of fall and stay safe and active. That's really what fall prevention is helping people stay safe and active and not fearful and injured. So we always start with defining what is a fall. It doesn't always mean falling to the ground. It just means that there was an unexpected change in your position. So if you, for example, stand up from a chair and then sit back down by accident, that's not what you were intending to do. That's technically a fall. Um, of course, it's not as worrisome as the dramatic falls to the ground, right? And it usually doesn't cause injury. But I think it's really an opportunity to look at like why is that happening? Could something be changed with for me or for my loved one that would make that less risky? So I think it's important to pay attention to those little losses of balance that we didn't intend. Um, that are still technically falls, but we really don't talk about and worry about as much. So I wanted to just start with a few beliefs about falls that I hear from family and patients all the time. One is if I stay home, I can avoid falls. And I do wish I could see you all and see if anyone feels like this is true. But this is one that I hear a lot. Definitely, at least half of falls happen in the house. So staying home doesn't mean that you will avoid falls. And in fact, we were talking a bit before we started the official presentation that often at home we're more relaxed, right? We're kind of used to how the environment is and we're not paying as much attention as when we're in somebody else's home or out in a busy space. So this is one aspect that contributes to falls in the house.
Jamie, if
Yes.
you like, we
Mhm.
can have people raise their hands when you ask a question, so
I
then you
know.
can at least see the raised hands.
I thought about that. I'm just not sure if I can see you since I'm having trouble seeing you when the presentation's up. We could try it and
Yeah,
see what I see.
if you ask them to raise their
Yeah.
hands,
Okay.
at least I can count the
Oh,
hands.
you could count. Yes. How about the
Does
next
that
one? If I
does that
limit
work?
my
Yes, yes.
Yeah, if I limit my activity, I won't fall. So reducing activity or avoiding activities will help us not fall. How many people feel like that might be true?
So if you all feel that that might be true, you can raise your hands, which is by clicking on the little red. That's the other thing I didn't educate to how do you raise your hand.
Ah.
So, well, I see one.
Good. Oh, one. Okay. Okay. Well,
So it's
one
a matter
is
of clicking on the raise hand, folks.
And we'll have a few more of these so we can practice.
Yeah.
But yeah, largely reducing activity decreases strength, and we'll talk more about this. But whereas staying physically, the more people stay physically active, the stronger and steadier they are. So we haven't shown that limiting yourself really helps, with the exception of maybe roofs and ladders, might be the one exception. I hear this one all the time. Muscle strength and balance cannot be improved as you age. Anyone want to say that they feel like that is true by raising their hand? And I'm not sure I can see the hands.
Yeah,
Yeah.
there are
Okay.
no hands. I
Oh,
think
okay.
they're thinking
Well,
that's a
even
trick question. Now
it
we
is a
have
little
a
trick
hand.
question. No, yeah, muscle and strength can be changed at any age. It really has to do more with the stimulus, right? That we're putting the right load on the muscles, and the right challenge to our balance to change it. It's not as easy as it was at 20. I swear that the 20-year-olds can look at the barbell and they get stronger. As we age, we have more work to do to get there, but we can definitely still change things. And then yeah, I hear this one every day as a PT. Well, using a cane or a walker will make me dependent on it. Um, Generally, walking aids are a tool. They're like wearing a better pair of shoes that helps you walk better. It's not that you can't get stronger and better balance while using a cane or a walker. If it helps you be more mobile, then that's a win. I will say for persons with dementia, sometimes mobility aids actually increase fall risk, especially if they're not able to use it correctly, or it's not most likely if it's not familiar to them, it's going to be harder to use, and often I see increased risk with that. So that's kind of the one exception. Okay, so who falls? Generally, when we look at all older adults over 65, one out of every four will fall every year. When we look, and they're more likely to be female than male. Um, Oops, sorry. Yeah, when we look at persons with dementia, we see that two to three out of every four will fall every year. So a much higher rate of falls in our people with dementia. And even though men fall less often than women, men are more likely to die from a fall than women are. So that has to do, I think that's still embedded in some stereotypes of men engaging in riskier activities like getting on roofs, ladders, doing this heavier activity that has a bigger risk associated with it. This is a cycle of falling that I was kind of referring to with activity limits. So you can see when somebody has a fall, a lot of times they naturally restrict their activity because you're worried, right? Which is a natural response. And then when you limit your activity, then it actually makes your strength and balance a little bit less. You're not moving around as much or going out as much, and that can cause some isolation. Depression and anxiety add to fall risk. And then we lose physical fitness over time and develop an increased fear of falling. And this cycle can perpetuate itself, if somebody doesn't consciously feel like they can break out of it. So this is a big reason we do these classes, is to help you know, like, what can you do about falls so that you feel like you have more control, and the only strategy isn't just to stay home or limit your activity. This slide is pretty busy, but the main thing I want you to take away from it is that there are a lot of things that contribute to falls, right? These are the risk factors for falls. And on the left are things that you can change, and on the right are things that you can't change. The list of things you can change is bigger. So we have more opportunity than we have not. And the things we can't change are age and changes that happen with age. So, like, our reaction time gets a little bit less, our multitasking gets a little less. Reduces in ability. We tend to get more chronic conditions, dementia being one of them. And then anytime somebody has an acute illness, like the flu or pneumonia, or is in the hospital, these all increase risk of falls. While we can manage some of those, we can't really control or stop or reverse them. So we're going to talk about this list on the left today. Oh, I missed one big thing there. At the bottom, the other thing I really hope you take away from this presentation is that falls are not this inevitable part of aging, right? Gravity exists for everybody, and so falls are always possible, but it doesn't, as you age, it shouldn't just be something that we expect is going to happen, and that we have to, like, tolerate. Again, one little exception with dementia is that when we get to later stages of dementia, falls are often part of that picture, and they're just part of what happens as the body is changing so much. And so we certainly often cannot prevent all the falls as somebody's dementia progresses, but earlier on, there are many things we can do, and I hope you'll find some of those today. So when we think about specific risk factors for people with dementia, there is just a slower processing of information, right? You probably noticed this with your loved ones that it takes more time, especially if the processing is needed verbally. There is a decline in the cognitive processes that regulate and manage our thoughts and actions. So, one thing that we talk a lot about when I'm teaching healthcare providers about thinking about falls in people with dementia is thinking about these unmet needs. So normally, like if you're sitting here in this talk and you're uncomfortable, you might wiggle around, shift yourself around, you might stand up, stretch, and that might be perfectly appropriate for you to do. It may or may not be appropriate for somebody with dementia, right? If they need help to stand up or um, maybe the chair is on rollers or what have you. Um, this idea that somebody may be hungry, need to use the bathroom, be uncomfortable, and may not be able to communicate that in the usual ways, and may not be able to assess whether it's the right time to do it. They may just act more on that instinct to do it, and that sometimes leads to a fall. There's also a decline in the ability to multitask, even more so than just normal aging. And so another thing I often talk to my patients about is their caregivers is not having a conversation while we're on a walk, letting somebody just walk and then having the conversation after when they're seated and they can pay attention because at least the patients I'm seeing need all of their attention on the walking at that point. But background noise can do that. We filter out those things without really thinking about it. But when the brain has changes with dementia, it has a harder time filtering those out. And then just this ability to adapt to our environment as it changes. So if you're walking down the street and suddenly a car backs out of the driveway, that ability to decide what to do in the moment, to stop, to take a step back, to speed up, to get out of the way, whatever it is, that can be really hard for somebody with dementia to try to interpret which motion they should do. And so all of these contribute to their risk. This slide shows all of the people that can help with falls in healthcare, and so there's a lot of people that can be on the team of helping reduce falls. In the center of all that is you and your family. So you're hopefully driving all the things that need to be done, and then the primary care team. We'll talk about that middle section last, and I'm going to start on the kind of with the other health care team members on the outside of the circle, starting with exercise, so members of that team are often physical therapists, of course, and then Tai Chi instructors, community exercise instructors are all in that realm. So a complete, I've debated actually about putting the slide in. There are three components to a complete exercise program, and I wanted to share them with you for a couple of reasons. And my hope is it doesn't overwhelm you, because I think as a caregiver there is a lot that you're already doing, and you don't have to do all of these things for yourself or your loved one to prevent falls, right? You can pick the lowest hanging fruit, the ones that are the easiest to get to for you, and that might make a big difference. But you often don't need to do everything. So if you're already doing some exercise or your person with dementia is already doing some exercise, fantastic. All exercise is good. What we know about fall risk is that if we do endurance, strengthening, and balance training, that is the most impact on falls. So that's like the gold standard. It's like you ate all of your vegetables, and you followed your food pyramid exactly for the week. So we don't often get all of that done, but is what we know works best. So endurance activity is things that get your heart rate up. Sustained movement would be like going on a walk, dancing, Tai Chi fits in that category, gardening, just things where you're getting your heart rate up and you're doing it for a while. They recommend 150 minutes a week, which works out to be about 30 minutes, 5 days a week, of that kind of activity. When we're thinking about somebody with dementia, a familiar and enjoyable activity is best. I would say an enjoyable activity is best for everyone, but something, versus like an abstract exercise that they've not participated in before or really enjoy. I wouldn't I never encourage my patients with dementia to do something in that realm because it's not very effective. Um, and then the second ingredient is strengthening. So this is something that makes muscles work harder. So it's something that you don't sustain like an endurance activity, but you do 8 to 12 repetitions. So this can be like weightlifting. It could be body weight exercises like push-ups or squats. Things like Pilates and yoga fall into that. We'll see Tai Chi here again. And then again, familiar and enjoyable activities are best. So if you've ever been to PT, we can give some really complicated, weird exercises sometimes to target certain muscles. That is not what we do when somebody with dementia comes to see us. We're going to pick something familiar, a very functional exercise. Usually, like sit to stand is a really good one, sitting up and down from a chair, something that is familiar. So if somebody has weight trained before, that often does work, but it might be taking stairs and doing sit to stands for lower body strength because those are familiar activities and we tend to hold on to um, procedural memory. So memory of activities that we've done over and over and over again in our life. We hold on to those the best and the longest. So they're the easiest to access when we're trying to get more exercise. And then balance training is that third ingredient. And this is actually the most important one for fall prevention. I also find it's the one that patients generally know the least that they needed to be doing. So balance is anything that challenges your coordination. So it can be dance. We see Tai Chi again, yoga. It can be standing on one foot. It can be standing heel to toe or walking heel to toe. Just anything that challenges your coordination. I have prescribed kitchen dancing for patients before as a balance, it's balance exercise 3 times a week. You're going to dance in the kitchen for 15 minutes to your favorite music. And that might be it's fun. People engage in it, at least if they like to dance, right? And then music, as you might know, for somebody with dementia, can be really engaging. I think music is engaging for all of us, but it kind of bypasses that conscious part of our brain and lets us get into some natural rhythm, whether we actually have rhythm or not. It lets us pretend like we do. But overall, the best exercise is the one that you will do or that your loved one will do. So those are the magic ingredients: balance, strength, aerobic exercise. But if you're doing one of those and you can add something, that's fantastic. If you're doing none of them, starting with balance might be your best one. Um, but really the one you will do is awesome. We promote Tai Chi a lot because it's been studied a lot, honestly. And it has, out of all the exercise that they've looked at for fall prevention, it has consistently been shown to be the most effective. So when somebody participates for 12 weeks, 3 times a week, we see reducing fall risk by half. So 50% reduction, which is huge. And then it helps balance strength, aerobic capacity. It also can help with symptoms of anxiety and depression, and it's low impact. The picture here is showing seated Tai Chi, but it is traditionally done standing and can be modified to sitting as well. There are some online resources in the handouts that I sent for Tai Chi videos. There's, like a short 7-minute one, a 12-minute one. If you just have time to get a little bit in, those can be kind of nice resources. Oh, and there's what that handout looks like. Oh, I did want to say Providence does offer a free class through Base Camp. It's open to anyone. You don't have to be a patient at Providence. They have beginner and advanced Tai Chi classes, and it's in person at St. Vincent's, but it's also online. Every class is online, so you can participate from home that way as well. So when we think about balance, there are several sensory systems that contribute to balance. And so keeping these sensory systems optimized helps helps our balance. So getting your vision checked regularly, keeping glasses clean, which I know seems silly, but I can't tell you the number of times I put my glasses on in the morning and I think, how did I see through these yesterday? They've gotten so dirty during the day. So particularly when somebody isn't cleaning their own glasses or may not realize they need to be cleaned, paying attention to the cleanliness of them can be helpful. Using sunglasses to reduce glare, our eyes just do not accommodate between light and dark as quickly as we age. And then there is good evidence for treating cataracts when it's recommended that can help reduce fall risk. So some vision tips when you're walking with your person with dementia, you may notice things they don't. A lot of times vision gets some kind of more narrowed and centralized, and we don't take in as much peripheral vision as dementia develops. So helping take in that wide view for somebody and steering somebody towards safety, meaning, if there's a big crowd coming or a car coming, just kind of naturally taking them out of that path. Also, vision can change with dementia so that it's hard to recognize shadows and puddles and changes in surface if they're what they are and how to respond to them. So again, kind of just steering somebody away from some of those if there's an option to. And then naturally pausing when you come indoors. So if you enter the building with uh, your loved one, just pausing and letting their eyes adjust to the light can be helpful because that does take longer as we age. And then in general, when you're thinking about your home, having good lighting, especially at night, there are plenty of night lights that come on at dusk or they're, on online, you can order motion LED strips that you can put down a hallway that will just light up when somebody walks with the motion, which is kind of nice for lighting the flooring. Um, Using this high contrast on steps that you see over to the right. So you see a red step with a white edge. If you look at steps for most buildings, there is either a color strip on the edge or some sort of texture change, like some ribbing in the cement sidewalks. This is sometimes both for traction, but also visually, we catch the edge with our eye better when that's there. So it means that we don't have to pay as much attention to it, right? The eye can catch it a little easier. And then sometimes using color to help attract where you want somebody to reach or to use a rail. So in the case of that red rail on a white wall, that's going to really stand out to somebody with dementia and be more likely that they reach for it versus the white rail on the white wall is harder to see and their brain is not going to naturally reach for it as easily. Making sure you have secure handrails on all steps is important as well. Um, Multifocal lenses do make it difficult to see the change in curbs and stairs, or even any outdoor surfaces. So a lot of times when I have patients with balance issues, that is one thing we're talking about is getting a single distance pair of glasses for outside walking and activities. So it kind of depends on how active somebody is, whether that's really useful. But the reason is like if you're looking down at the step, it's through your reader part of your progressives or your bifocal, and so it's distorted. And a lot of times we handle that fine, but when somebody starts to have balance issues, they often rely more on their vision. And so if it's not reliable, that can create more problems than it helps with. So the other sensory system we use besides our vision is our inner ear. It tells you where upright is. As you age, it can get weak just from disuse, and so balance exercise can help with that. But people can also develop vertigo. That often is from the inner ear. Vertigo is also, again, not a normal part of aging. There is generally something that's causing that we can do something about. And some of the solutions are really easy. If you have vertigo or just you notice that your loved one is reporting dizziness or unsteadiness or showing signs of dizziness when they get out of bed, bend over, look up, or roll, those four motions. That is something I would talk to the primary care provider about or a physical therapist because there's a condition in the inner ear that's really easy to treat. And when those motion, the more of those motions that create that vertigo or instability, the more likely it is that you have that. We're learning more and more that hearing is part of balance as well. So wearing hearing aids, as long as they haven't become irritating, has been shown to be helpful. And this is in the general population versus just folks with dementia. Getting regular hearing checks or sooner if you notice a change to keep that sense sharp. And then we also get information from our feet. So we feel the ground underneath of us, and that helps us know where we are in space. That being said, we know that more people fall when they go barefoot or wear socks only in the house, or worse, flip-flops or sandals, something without a back. And part of that is that if you're walking and you misstep in some way, which we all do from time to time, you might be able to catch yourself if that shoe goes with you. But if you accidentally step out of the shoe or slip out of the shoe, sometimes that actually contributes to the fall. So again, you don't have to do all of these things to change your fall risk, but sometimes this is a nice low-hanging fruit, right? Just throw out the flip-flops, the backless slippers, and get a good pair with a sole and a back on them, and use them inside and outside the house. We don't walk well on painful, numb feet, right? That doesn't feel very good. So seeing a podiatrist to help find the best support for your feet can be helpful if those are issues. Good. So when we think of home safety, really our occupational therapists, so my colleagues in rehab, are the best at assessing home safety, and specifically for persons with dementia, I think an occupational therapist consult is helpful. It is fairly easy to get an occupational therapist out to your house if your person with dementia is what we call homebound, so they're not leaving the house regularly without assistance, um, and that they can't do that safely, they would qualify for home therapy to come out and do an assessment. And that will be very individualized to their specific needs. And that can really help somebody stay safe and independent in the home, or at maximally independent, I should say. Like I said, there is a home safety assessment booklet developed by an OT that I included in the handouts. One thing that you can think about is grab bars if you don't already have them, or where you might add more. But anytime you see somebody reaching for something, like a common example is this garage step in the upper right. So as somebody steps in over that threshold, oftentimes I'll see patients reach for like the molding to hold on to the door frame or the doorknob. Neither of these are great options. The door knob is going to pull the door towards them, right? And the door frame molding is not really meant to be pulled on repeatedly over time. It's hard to grip. So that's a great example of a place to put a grab bar. Grab bars are mounted into the studs, and so they're meant to hold weight and meant to be pulled on. In the lower
Amy,
picture, yeah.
can I interrupt you just a second talking about grab bars so I don't
Yeah.
forget? How about all of the suction grab
Mm,
bars that you see?
yeah.
Are they
So
safe? Are they usable?
somewhat. Um, they are they're good. I think they're best used temporarily. So they eventually lose their suction is the problem. So they'll work for a while, and then one day you'll come in and they'll just have fallen off the wall. So if somebody uses those, I usually encourage them to check it every time before they get into the shower. So in the case if somebody with dementia is using it, I would say that the caregiver needs to be checking that every day. Just give it a tug and make sure it's still sealed, because they just lose their suction over time. But they're easy to install, and they can be put on glass doors or fiberglass showers, whereas it's harder to install grab bars in those situations. So they do have some role. They just take some caution and awareness. Yeah, it's a good question. They also make a tub clamp bar, which I didn't show here, but they are clamped to the edge of the tub. So they also don't require any drilling or installation, but a handle kind of as you step up and over the side of the tub, which can be helpful if you don't have a place or the skill to install a grab bar. I definitely like to recommend grab bars wherever, if somebody is reaching for towel racks, because towel racks are not typically installed into the studs and they are not meant to be pulled on. So this would be a good example of like color coding that grab bar to make it more visually attractive, and hiding the towel bar with a towel or taking it off the wall, so that it's not something the brain sees and wants to pull on. Because it looks like something that should be pulled on, but it isn't. Other simple, somewhat obvious modifications, but always worth being said because we're humans and these things happen, right? Keeping clutter off of your stairs and out of walking paths. Um, picking up toys like kids' toys from grandchildren, maybe, or pet toys, making sure those are out of the way. Making sure cords are taped, and not anywhere near where somebody's feet might be. And then I'm a big fan of either getting rid of throw rugs altogether, or double-sided tape is pretty nifty. My mom was living with us the last few years, and I taped all our rugs down with this double-sided tape, and I'm super happy that it did not ruin any of my floors. But that's available. I just got it at Fred Meyer's. Sometimes called rug tape, Gorilla tape. It'll say double-sided tape, that is meant for rugs. But it basically keeps the edges down so they don't ball up under your feet or the rug doesn't shift. Pets can cause a lot of falls. And this is a hard one, right? Like we all love our pets. But about a third of falls in the home are caused by cats and dogs, and more fall-related injuries are caused by dogs than cats. Um, Making sure that pet toys are picked up, making sure your pets are as trained as they can be, or that they're kept separated. Like a baby gate can work really well for keeping a pet in a different area, if they need to be, while somebody's moving around. And then I have had conversations with my families that have a person with dementia about whether or not they should get a new pet. Like a new puppy running under feet isn't always ideal, even though there are lots of lovely things about puppies. But something to think about if somebody's really having challenges with their mobility. Therapy experts are can be helpful for anyone with fall prevention, but I think when we specifically think about people with dementia, we use different teaching techniques when we're working with somebody who has dementia, because learning is not the same. Most of us with normal cognition will learn by error, right? So if you go to stand up from a chair and you don't generate enough force because the chair was lower than you thought, the second time you do it, you'll often generate that force, or you'll use your hands. So the error made you do it differently. We don't see that kind of learning in dementia. That the person with dementia may commit the same error over and over, which is obviously really frustrating and not very helpful. So we use what we call errorless learning. So we try to set up an exercise or environment to where that error can't happen. So in that example, we would make the chair high enough that they can practice it to stand safely without having the fall back into the chair, or committing the error. Um, so we use different strategies. We use a lot more visual cues and less verbal cues, because that's easier for the brain to process when somebody has dementia. I mentioned mobility that devices aren't always as useful when somebody has dementia. So I think we can do a good job evaluating whether that's actually a helpful tool or not. I mentioned our OTs for home safety, but they also do functional cognitive assessments, which is really assessing. It's different than some of the clinical tests that the primary care or neurologist might do, in that they're assessing how somebody problem solves and what structure and cues would help them stay maximally independent. So it's very function based and less like language and processing and memory based. Sometimes people have a lot more functional cognitive ability than they might have on some of the language and memory tests. So I think seeing an OT for that assessment can be helpful. And then speech therapists, I recommend my patients sometimes see speech therapy when they're having difficulty with communication strategies, like a caregiver and their loved one aren't able to communicate effectively, and that's leading to some fall risk because they're miscommunicating. They can be helpful with that. And then there is some evidence about cognitive training programs, so they might help refer or develop a cognitive training program that often when combined with physical exercise can slow some of the decline in balance and mobility that we see with dementia. Okay, so we talked about this whole outer circle. So your vision and your optometrists are helpful, podiatrists and footwear. We talked about home safety and then strength and balance. So now we're going to move to that inner circle of the primary care team and talk about their role. So in an ideal world, you are talking to primary care about, and I think in this context, for our patients with dementia, there's often a neurologist involved, talking to these people about falls, and hopefully they are also asking you about it. Um, we are not perfect as a healthcare system with asking, so sometimes you have to tell us. But talking about fall risk with these healthcare providers and asking about medications or conditions that you or your loved one have that might contribute. Because often managing those conditions, or we'll talk more about medications, can help reduce risk. Keep track of falls or near misses. Usually, the more information you can give the provider, the more helpful they can be in sussing out what might be some of those solutions. Having an updated medication list and reviewing that at least once a year with your provider, all your medications. So sometimes people are going to different specialists, and those specialists have recommended different medications. And sometimes not everyone is thinking about all the things that you're taking. So I think sitting down once a year and looking at that to see if it's still the right things for you or your loved one is a good idea. In general, the more medications you're on, the more that impairs risk, right? The more medications you're on, the more they tend to have interactions with each other, and that is part of what impairs our or increases our risk. So we know that four or more medications increase risk, which a lot of people are on four or more medications. But we know when we get up to like 9 medications, then for sure things are starting to interact with each other. So I think really talking about the medications that you're taking and if they're all still needed is a good idea. So I'm not going to go in great detail because I'm not a pharmacist, but I wanted to give you the categories of medications that are often the culprits of of the biggest fall risk. These are medications that slow down your reaction time. They can create confusion or dizziness, or they low pressure. So medications we would use for nausea or pain, especially the couple that are listed on there. Some of the older generation antidepressant or anxiety medications can elevate risk. Muscle relaxants, which are sometimes prescribed after a fall, if you're in pain, it's ironically can also add to risk. Things that usually for urinary incontinence also have some risk. And then, of course, sleeping pills. There is really no sleep medication that doesn't increase fall risk because they intentionally kind of shut your brain down and try to make you sleepy. So that slows you down and makes you not as able to balance and move. Um, the other thing I wanted to point out on here are over-the-counter products. So we often think that things you can buy in the store are safe, right? They're available to everyone. There are all the products that say PM, like Tylenol PM, Advil PM. These all contain Benadryl, and that makes you sleepy. Makes most people quite sleepy. So it can slow people's thinking down, slow their reaction down. And that PM, I will say, is very small sometimes. I mentioned my mom was living with us the last few years, and she didn't take her glasses to the store one time and came back with Tylenol PM. But the PM was so small, it was hard to even see. So it's worth really looking at what you're buying and making sure that it's just the product you want and doesn't have extra stuff in it that might make you dizzy or off balance. And then we'll talk more about alcohol, not so much a medication, but definitely a drug that impairs our ability to move well. So some of the best practices when you're thinking about high risk meds, oftentimes people are taking a high risk medication and they need to be taking it. So I think just making sure you're having that conversation with your provider every year, asking, can this be stopped or do I still need it? Is there a safer option for me? So for example, if you're taking an opioid for pain, try and schedule Tylenol is a much safer option. And when we talk about persons with dementia and pain, a lot of pain medications are prescribed as needed, but your person may or may not be able to tell you that they need the medication, right? And they might not have any pain until they try to get up and move. So often a scheduled medication for pain like Tylenol can help somebody stay more active if they have known arthritis or that they have pain. That's something I would encourage you to talk to their provider about. And then, if I still need this medication, it's high risk, can I take less of it? A lot of times as we age, we don't need as much of the drug because we process it slower. And so we need less to actually be effective. So that's always worth asking. Um, I don't think anyone probably thinks that alcohol helps them move better, right? That's not what it's known for. So it increases fall risk. It also interacts with about half of prescribed medications. So if you're drinking alcohol and you're on prescribed medications, I think it's worth discussing with your provider what the risks are with that. Um, and then the daily recommended limit, this is not a recommendation like you should drink it, but a recommended limit is 2 drinks daily for men and 1 for women. So over on the right, we have what those drinks are. So it's a 12-ounce beer at 5%, which if you're a beer drinker, which I like to drink beer, it often is served to me in a 20-ounce container. And it may or may not, it may be higher than 5%. So it's really worth paying attention to both the amount of alcohol in it and the size of it when you're thinking about how much you're having. Similar with wine, a serving of wine is 5 ounces. And if you're a wine drinker, I would encourage you to measure out 5 ounces and see how small that is. It is not a full wine glass. It's usually like a third of the glass, depending on how it's shaped, but it's much less than you would think as a serving. And then for shots, it's 1.5 ounces if you're having a cocktail or hard liquor. And I will just say, I think many people, including older adults, get in trouble with the way that alcohol is served, not realizing that the portion is much bigger than intended. So just again, something to pay attention to. Blood pressure. As we age, often our blood pressure doesn't respond as quickly when we change positions. So like when we stand up from a chair or get up from a low position, it should go up when we stand up. As we age, sometimes it doesn't respond as quick and it might drop for a period of time. This is also really common in persons with dementia, and they may or may not be able to say, I have symptoms or I feel off balance when I stand up. Um, and so it's worth, if you're noticing imbalance when somebody stands up or comes up out of bed, it's a good opportunity to take a blood pressure in that position and see, is it in fact getting too low compared to how it was when they were laying down. The more medications, particularly if somebody's on multiple medications for blood pressure, it can make this worse, this ability to increase your blood pressure when you stand up. And as I mentioned, about 50% of falls in persons, particularly with Parkinson's or Lewy body dementias, or unexplained falls. So we didn't trip on anything, we can't explain it by any other way, can be explained by this low blood pressure. So again, worth something to bring up to your provider if you're noticing that. The general recommendation is to drink, that kind of standard 8 ounce glasses is pretty still holds true. It needs to be non-alcoholic and non-caffeinated to count in that 50 to 60 ounces. And then there are medications that can help prevent it. They may prevent falls, but they particularly can also prevent injury from a fall. So vitamin D is known to increase muscle strength, and it can reduce the risk of falls and fracture, um, or fracture from a fall. You want to be taking vitamin D3, which is a more active form, not D2. And you want to get a minimum of 1,000 to 2,000 units a day through a supplement. I would encourage you to talk to your provider and make sure that you can recommend the, excuse me, the right amount for you. But we generally don't get enough vitamin D in the Northwest. Most people are deficient because we don't have sun for many months out of the year. And then, when we think about our persons with dementia, they may or may not be able to get out as much as they used to. Um, and the main way we get vitamin D is through the sun. It is available in some foods, but they're not foods that you probably eat every day, like anchovies and sardines. Leafy greens often have vitamin D as well. And then calcium is the partner to vitamin D. It helps keep strong bones. You can get calcium from food most of the time, but you can also supplement with it if you're not able to. And you can go online and see if you say like calcium calculator. There are many calculators online that will help you kind of figure out how much you're probably getting from the food that you eat. Okay. So that leads into a conversation about osteoporosis because vitamin D3 and calcium both support our bone strength. Osteoporosis is a condition where the bones become more porous, like you see in the lower picture on the right. There are no symptoms for osteoporosis. Usually it is discovered when somebody has a fracture, unless they're being screened with a bone density test, which is called a DEXA, DEXA. It's much more common for women to have osteoporosis than men because we lose our hormones earlier in life, and those hormones were helping to drive our bone density. So they typically screen women earlier than men, but men can also get uh, osteoporosis, and particularly more so when they have dementia, because probably because of the decreased amount of activity and weight bearing, which also helps stimulate bones. So besides exercise, taking your vitamin D3 and calcium helps um, maintain bone strength, and then talking to your healthcare provider about bone density testing and then treatment if you do have osteoporosis. There is multiple medications that can help reverse osteoporosis and make your bones stronger. So these are just kind of an overview, kind of bringing together some of the things we've talked about. So strategies for reducing fall risk in persons with dementia during the day. And I realize, having been a caregiver fairly recently, that these are tall orders. So again, you don't have to do all these, but if there are bits that seem manageable to you, I hope that they're helpful. So helping anticipate needs. So I often like to talk about, when somebody has dementia, their personality does not change, right? If you're somebody that like to get up early in the morning, eat breakfast right away, have their coffee, or like to go on a morning walk, these structural things will be kind of ingrained, right? So as much as you can help facilitate that, it probably looks different than it used to. But getting up, if they're getting up early, continuing that pattern. If they like to eat right away, making sure that they eat. If they were somebody that ate often throughout the day, making sure that they have frequent meals and snacks. Because there was probably a reason they did that. Either their blood sugar got low or they got hungry, and they might find ways to try to make that happen, or can kind of appear restless or agitated when they're not getting those needs met. If somebody isn't sleeping well, really minimizing naps so that they can sleep well, because sleep really helps us function, helps the brain function better. I mentioned managing pain proactively. So if you know somebody has arthritis, seeing if you can talk to the provider about scheduling a medication. Tylenol is the most common one that our geriatricians use because it's the safest, usually has the least side effects. I mentioned nutrition, hydration is also important. Um, Somebody can quickly become dehydrated by not having that initiative to drink water because we know we need to. So making sure that they get the hydration every day. However, if that's knowing they need to drink 2 of these bottles or a glass with every meal, just making sure that they get it in. And then for nighttime, it's similar, anticipating needs. So whatever their routine was before, as close as you can match that is helpful because I think they're less likely to get up or get agitated or um, try to do things that we weren't planning on them doing maybe in that moment. Definitely toileting right before bed. And then if somebody always gets up at night to go to the bathroom, like for example, I get up every night between 2 and 3 o'clock. So if somebody's taking care of me and I have dementia, hopefully we can just they will just set a time and we'll just go to the bathroom then, right? Versus waking up in a panic and we've got to rush when we know that's likely to happen. Again, managing pain if somebody's having just trouble sleeping and appearing uncomfortable. There are a lot of other things, topicals that are pretty safe that your providers can recommend or the pharmacist can recommend. Heating pads can be helpful, or movement, of course, is helpful. Um, Again, if somebody is frequently hungry, having a snack there at the bed might be helpful. Those good night lights or motion detected lights can be helpful. And then trying to mimic prior sleep habits. So a lot of times I find that people are spending a really long time in bed when that's not, 12 hours maybe, when that's not their norm, right? So getting out of bed can help the sleep when we're in bed be better and somebody be less agitated or restless. Okay, so we talked about a lot of things. I would encourage you, if you didn't get a chance to fill out that self-assessment questionnaire, to go back and fill it out for yourself and your loved one and see what the specific risk factors are, and then think about what might be your lower hanging fruit. So, what are the easier things to do? Is it throwing out the flip-flops? Is it maybe using a distance pair of glasses when you're walking outside? Um, is it going through the medications with your primary care provider when you go in for that next visit? I think vitamin D and calcium are pretty low hanging fruit, right? They don't take a ton of effort on our part to do. So some of these things might be easier, whereas I feel like exercise and home safety are really big value for fall risk reduction, but they do take often a little more effort to change. So you can have some low hanging short term fruit and then some longer range goals that might help reduce risk. Okay, thank you so much for listening. I will stop sharing my screen and would love to hear questions that you have.
Oh, we did have a specific question related to medication that I think you may have answered. It
Oh,
was so specifically it says, do you know of any capitalized any
mm.
medications that can contribute to falling?
Oh yes, yes, there are many. And those categories I mentioned on the slide are the biggest ones. And then in your handout, it talks a little bit more about those highest ones. But they're typically anything that will make you sleepy, relaxed, drowsy, these kinds of symptoms, or blood pressure, multiple blood pressure agents. Those are probably the biggest culprits.
Thank you.
Yeah.
So we have some very specific questions related to dementia and falling.
Yeah.
And the first one is, what makes fall prevention different for someone living with dementia compared to an older adult who doesn't have cognitive impairment?
Yeah, I think a couple things come to mind. One, I think it's harder to prevent all the falls. right? Because the brain, because the dementia is progressive and changes over time. And so inevitably, I think it's hard to anticipate how you can't anticipate always how and when it's going to change. So that is different. I think doing these base things that I talked about, good shoe wear, good home safety, exercise, they all can help. But I think that is one difference. We can't prevent quite as many falls in dementia as we might in persons without dementia. Um, the other thing, that's different is kind of what I was just talking about, those unmet needs. When somebody has normal cognition, they can better assess whether it's the safe time to do something, whether they need more water, whether they're getting hungry, or they need to go to the bathroom. As dementia progresses, somebody may not be able to assess those things on their own. And that can lead to accidents, it can lead to rushing, it can lead to all sorts of things that contribute to a fall. So again, understanding, I think caregivers are in this unique position of knowing their person well and observing them a lot. And I would really encourage you to embrace what you know about your person, and what they were like before dementia, to figure out the best ways to support them. Did that, I don't know who asked that question, but did that answer that question for you?
I think that really did. And then we want to flip back to medications again.
Oh, yeah.
So the question is, what about antipsychotics?
Yes, those are also in the fall risk. Most of the presentation I took from the presentation I gave today, I took from our standard one and then inserted some things about dementia. But antipsychotics are more commonly prescribed, of course, in persons with dementia, and they do have some risk. So it doesn't mean that they shouldn't be used or shouldn't be taken. I think it's really worth having a conversation with the provider about, like, is this doing what we need it to do? And is that enough value to absorb the risk? Or is it caught, have I noticed a bunch of falls happen since they started taking this, and it's also maybe not helping in the way we thought it was going to help? Because medications are not perfect science, right? They don't always help exactly as intended with their prescription. Um, so I think, yeah, really weighing the value of that with your provider and the pharmacist is a good idea.
Can you speak to the changes in dementia, such as judgment,
Mhm.
depth perception,
Mhm.
spatial awareness, attention, or balance that can increase fall risk?
Yeah. Let's see. So judgment, we talked a little bit about, I think, harder to respond to changes in the environment, or whether it's an appropriate time to move in the environment. Um, so that is really where caregivers, I think, are helpful, is and both anticipating needs, but then also helping steer somebody towards the safest path and making those decisions. Um, Attention definitely can become very focused in dementia, and not as, a lot of times when we're walking through a busy place, naturally we're taking a lot of information. But somebody with dementia might be just more focused on where they're going and less attentive to all the other hazards and things happening around them. So again, this is where I think a caregiver can be helpful in helping them navigate that. And they will eventually need help navigating that. Um, Shoot, I forgot. There was attention, judgment,
Spatial awareness is a big
facial
one.
awareness. Oh, yes. Yeah, again, patients can get pretty focused on, where they are in space and less attentive to the entire environment. And then I think visually things can look different, right? My understanding is that things, as somebody progresses with dementia, initially it kind of looks a little bit like a scuba mask. So we just have this central vision without a lot of periphery, and that can get smaller and smaller as the dementia progresses. So they're reliant on other people to help take that wider visual view. And then the depth perception, I think that was part of that question as well. Not just the glasses I talked about, but part of the dementia is harder. It's harder to tell if something is a shadow or a hole. It's hard to tell what it is. The brain isn't able to interpret it as easy. And so helping steer people around those things. If you see them, or I've talked to my patients about, yeah, as much as you can at home, trying to have sidewalks level, concrete level, taking out those variables as much as possible for people um, to help them navigate it.
And while we're talking about balance,
Mhm.
can you speak a little bit to walkers and dementia? And what kind are the best? And is there a point when they're not any good anymore? And those kind of questions.
Yeah, yeah.
The example that I can give you is that when my husband was in memory care,
Mhm.
they were very frustrated with him because he would not use his walker. And basically, what he would do is pick it up and carry it because he didn't understand what it was for.
Yeah,
So,
yeah.
could you talk about that a little bit?
Yeah, I think the use of any kind of assisted device like a walker or hiking poles or cane is very individual to each person with dementia. There's really not a blanket answer. My experience is that if somebody has been familiar with a walker, like they've used it in the past, that procedural memory makes it easier to use. If it's a totally new thing, they've never used it, it's not intuitive. And it becomes more of a hazard because they can't do that new learning to use it. So I would say more often than not, when I have a patient coming in with dementia, I am often getting rid of assistive devices more often than I'm issuing them because they're not proving to be useful. So it's sort of relieving the family and caregivers from like continuing to try to use this thing. I think what does work well, if an assistive device is not, is actually, holding somebody's hand. That is how a lot of the skills that we lose in dementia are somewhat mobility skills are in reverse of how we gained them when we were learning to walk. We kind of lose them in reverse order. But we often learned to grip things. We used a handhold to walk with, and those reflexes and that is very comforting often to people to have a handhold assist. And so that is often a way I teach providers to help persons with dementia move in the clinic is through a handhold assist, not a lot of words and a word assisted device.
So do you have recommendations that families should be looking for when they're doing a safety check room by room at home?
Yeah, that booklet that I sent with from the occupational therapist will kind of take you room by room and go through different safety hazards. Some of them are fall related, like looking at rugs and lighting, trip hazards. Are the pathways clear? Where is somebody reaching when they go to stand up? And then some are more other kinds of safety, like are toxic chemicals locked up, are guns put away and locked up, these kinds of things. So lots of different types of safety considerations in that booklet. But it may take a little bit to go through, but I think it's worth making your way through if you haven't had an in-person assessment with a home health OT.
That is actually an excellent booklet that I plan to give to all of my group members. So
Mhm.
thank
Oh,
you very
oh
much
yeah,
for that.
yeah, yeah. You're welcome.
So, are there home safety recommendations that may actually cause confusion or increase risk? And we just talked about the walkers.
Home safety that may increase risk. Um, I can't think of a typical home safety recommendation that would increase risk, except for we talked about the suction grab bars. Those if they, aren't checked regularly could increase risk. Um, certainly a bath bench or things that are really unfamiliar, unintuitive could. So I think always seeing how somebody responds to the measure is good. But I can't think. I think things like bed alarms. We didn't talk about those, but like chair alarms. So when somebody unweights, it makes a noise. Those could increase risk just because they're loud and scary, and we often don't. It's disorienting where they're coming from. Um, so those we I mean many of the hospital settings and nursing care facilities have gone away from those. So if somebody was using that at home, it could be increasing risk in an unintended way. But I can't think of a lot of generally most of the home safety recommendations are pretty safe.
We have a question related to um, late stage dementia, uh, multiple falls a week. Is a wheelchair preferable to a walker?
Hmm. I think that yes, with unfortunately with diseases like dementia that progress, there does become a point where perhaps ambulation is too risky and the value of it is not there anymore. So if somebody's falling multiple times a week and we've kind of already met with the primary care provider, they've had an occupational or physical therapist out to the house. They've made all the recommended adjustments, and the person is still having a lot of falls. It may be an indication that it's time to move to wheelchair as the primary mobility. Um, yeah, I think that's a good observation. And again, pretty individualized. There's not like this many years out, it's going to be wheelchair use. It's very individualized.
So, how do you get a physical therapist or an occupational therapist out to the house to help with the assessment?
Yeah, somebody generally for all Medicare guidelines, which most insurances follow, um, you need to be homebound. And homebound means that the person can't leave the house safely on their own. So it doesn't mean that they're not leaving the house at all, but it means they couldn't leave without their caregiver and do it safely. Um, and that should qualify somebody for home health to come out. And then it's just a matter of having your primary care make that referral. There are a few unique rules that get kind of clunky about that. You have to have seen the referring provider within 60 days for an in-person visit. And then they have to code it right. So there's a few things that the provider should pay attention to when if you ask for a home health referral. But yeah, if somebody isn't able to leave the house safely on their own, they should qualify for home health.
Okay. And do the providers know what those CPT codes are? Sorry. Sorry about that.
I know. In theory, I think there's like a joint, at least at Providence, there's this joint effort between the providers doing their best, and then home health sometimes reaching back out and saying, "Hey, this isn't the right code. Would something else work?" So sometimes it takes a few tries to get the right code because the coding is needlessly complex for a lot of the services that we have. But um, yeah, I think it's often a joint effort between the home health providers and the referring provider.
So, how can lighting, shadows,
Mm.
glare, flooring patterns, rugs, stairs, and color contrast affect someone with dementia? How's that for a big question?
I know, right? Okay. Yeah, so shadows, glare, patterns, all of these changes they take more processing. Um, and the brain has to constantly interpret, is that a change in height? How do I need to adjust? And somebody with dementia may not still have the capacity to be able to interpret that. So again, I'm often encouraging family members to get rid of extra rugs, um, trying to reduce shadows by having good light, trying to eliminate the as many surface changes as are realistic, so that somebody isn't having to overly work extra hard just to navigate within the house. Um, and I feel like there was more than, let me scroll back. Um,
I think
yeah,
you,
stairs.
yeah.
Yeah.
Um, one of the talking about color contrast and flooring patterns, I will never forget a lady who took these gigantic steps in the memory care
Mhm.
because of her vision and the way that she was seeing.
Mhm.
And at that point, I didn't really understand what was going on with her vision. Can you describe a little bit why people have difficulty with depth perception and things like that?
Yeah, I'm probably not the best at the science of why, but what I understand that they do see is that those color changes appear more flat. So say you see a puddle ahead of you, it might, we might see it as a puddle or intuitively know that it's in a puddle, most likely a puddle, whereas it could actually look more like a hole to somebody with dementia. It's harder to tell the depth of it. Ooh, and I probably should know the physiology of what happens to the eye that makes that happen. I think some of it is the brain processing, but I think there are actual changes into the actual eye itself that I'm not quite able to speak to. But I think, yeah, we know that the more changes of surface, the harder it is to tell what those are and how to respond to them and make a correct choice. So I think eliminating them as best we can on the floor, using color for drawing the eye somewhere you want somebody to go, like reaching for a rail or a grab bar, can be helpful, or a door you want them to go through, having that door be, visually attractive and appealing, and making the door you don't want them to go through more brown, nondescript, non-noticeable, like the brain doesn't pick it up as much. That is a strategy I've seen used in memory care facilities, but could, in theory, could be used in a home as well.
Well, that actually leads to the next question
Mhm.
and partially answered it, I think. What changes should we consider in the bathroom, the bedroom, the kitchen, and on stairs?
Yeah, yeah. So stairs, I think having some kind of contrast on the edge of the step, if possible. Um, Carpeted stairs are probably the hardest one to do that on, but you can add traction tape or colored tape to the edge. You could paint it depending on, again, on what kind of staircase it is, what it's made out of. Making sure there's good lighting, because if it's, nobody sees better in the dark. So the more light there is, the better. Um, Reducing glare, so having good lighting, but not a lot of glare coming in from outside or glaring lamps that are actually hitting somebody in the eye. Um, Sorry, as I talk, then I forget the rest of your question. Um,
No,
sorry,
I
was
think you
that
had pretty much covered it
okay?
prior, so
Okay.
that just added to it. But then there's another question that I hear our group members talk about all the time is about making the home safer without it look and feel institutional or
Mhm.
unnecessarily limiting independence.
Mhm. Yeah. I like we remodeled our bathroom fairly recently, and just installed a walk-in shower with a grab bar that is matches all the other furnishing. It's the same nickel that all the other furnishings are. I think ultimately that's the long-term solution, is that when we're doing remodels or houses are being built, that they're just putting in these safety features, because there is no reason not to have a grab bar in the shower. It's harder to install later. We often end up getting a cheap one that looks kind of medical. Um, so that's one thought. If you're remodeling your home, you have the choice to pick ones that they do make all of these things in the same fixture style that you would get your other fixtures in. Building in a bath bench, so it's like a seat on the wall with a handheld shower. Those can look quite nice compared to a bath bench. Um, oh, let's see, what else? I'm trying to think what else they might have been thinking of about institutional looking. Um,
I know
Okay.
that one thing that somebody had mentioned to me was talking about having bars along the wall,
Ah. Mhm.
like like they do in institutions, but to make it more
Mhm.
safe for their family to be able to stay at home longer. Is
Yeah.
that something that you've seen?
Yeah, that's a great idea because again, an assisted device might not work very well, but that ability to grasp and reach for things is something that lasts a long time and is a very kind of primitive ingrained reflex that we used, even when we were first learning to move. So having rails along the house could be really helpful. I think, I mean, it's going to look different, but I think, if you have the means to buy something that if your house is wood, you can make it look nice. Um, it depends. Anything can be done for a price, I suppose. But there are some. And I'm happy to forward these. There are some private pay occupational therapists that will do in-home assessments for a larger remodel. So the home health therapist is going to probably recommend easier to pick things like a grab bar you would buy at the store versus like remodeling your whole bathroom. So if somebody is looking at a remodel, there are several private pay OTs that will come out and individualize that and help you make some of those choices.
So when you recognize that you need to install some of this stuff, who
Mhm.
can do it?
Mhm. I know. This is actually what I'm thinking about doing in retirement. It is really hard to get a grab. If you just want a grab bar installed or a railing, just a railing put in, it's really hard to get a contractor to do that because it's not worth their time generally. If it's part of a larger remodel, then it's very easy to get them to do. Honestly, most of my patients get them installed through, family or friends that have those skills. Um, so yeah, I don't have a great answer for that. There are some companies like Reach. I'm trying to remember some of the other ones. I think I have. Trying to remember. I think I have some home remodeling resources um, for Clark County. I will see if I do and forward those if I do. But yeah, if income is restricted, there are some nonprofits that will do that sort of work. But if you can afford to pay, then it's often just a matter of finding somebody who will do it, which is hard. If you have any other remodeling that needs to be done, like when we did our bathroom, for example, I had them while they were here put a rail on our front steps. So if you have something else that you need to get a contractor out for, then they will often do those smaller jobs for you. But getting somebody to do small jobs is really hard.
Yeah. So how can we address safety when someone is wandering or moving around the house without simply restricting their movement altogether?
Yeah, I think the first thing I would do is think back about what we talked about with the unmet needs, why somebody might be wandering. Are they wandering because they're hungry, because they need to use the bathroom, they're bored, um, they need some movement. Like for me, I'm a pretty physically active person, so if I wasn't getting that activity, I am certain I would be wandering. Um, and maybe not at the most convenient time, right? So I think thinking about why somebody might be moving and are they getting all of their needs met that they had before as far as hunger, thirst, sleep, activity, social. If somebody's really social and they're not getting that socialization, sometimes they will wander or be kind of agitated because they're not getting that connection. So that would be the first thought. And then I think if you're removing those hazards as best you can, it gives them a little space to wander, right? So going through that home safety booklet, making sure that you got space that they can ideally most safely wander through, be my two thoughts on that.
So when should a change in mobility, such as walking or balance, or suddenly they're falling more frequently, when
Mhm.
should that prompt a medical evaluation rather than just be attributed to they have dementia and of course they're getting worse because of their dementia?
Yeah, I think anytime somebody is having a change in function, it's worth having that conversation with the provider or the healthcare team to do the due diligence of like, is this medication related? Is it blood pressure? Is it do we need you to be doing a little more strengthening? Like, are there things we can still do? Or are we at that point where we've done all the things and this is a disease progression? Because I think yeah, like I said, it's not the trajectory is not always the same for every person. But I think anytime you notice a change, it's worth connecting back to the care team to assess whether it's yeah, this is how it is now, or there's more that we can still do.
Can you distinguish between an OT and a PT referral? When would you request,
Mhm.
or should you request both?
Yeah, I mean, we do often work together, especially when we're coming out to a house. Um, but OTs, I would say, are very oh, they are really probably the most useful to you. And I say that as a PT. They're probably the most useful for people with dementia because they have a lot more training in vision, they have a lot more training in cognition, and they are kind of trained to always approach a whole person, which when the brain isn't working the same as it used to, it's really important to understand who that person was, what their likes and dislikes are, how they respond to things. And an OT will naturally do that. Um, a really good trained PT can do it too, but that is not, we are definitely a little more concretely trained to address muscle, injury. And so I think it takes a PT who's chosen to kind of specialize in that work to be as helpful in dementia. But generally, PTs are going to do a little more just general mobility, so gait, balance, bed mobility, whereas OTs are going to do a lot more with the functional cognition. So how does somebody function in their environment with their current cognition, and how can we set this environment up well for them? So we do partner a lot. But I think honestly, if I had to be biased, I would say OTs will be most helpful to everyone.
Are you aware of professional home safety companies that come out and do those assessments?
Mhm. Yeah, yeah, and I have a list of those. Those are private pay usually versus like a home health would be the one that's covered through insurance. But they are often OT companies. Sometimes they have a PT on staff, and I'm happy to send that list to you, Lynn, to forward to folks.
Okay.
Yeah.
So we're right to the end. Thank you very much.
Okay.
But we always like to ask this question, and that would be, what is it that you would like everyone to know?
Hmm. I'm gonna cheat and say two things.
We'll
One
let you.
One is I hope that you don't think falls are just inevitable and there's nothing we can do, because there are a lot of things we can do with and without dementia. And then I also think it's very common when somebody has dementia for everyone. It could be friends or family or health providers to kind of be nihilistic and think, this is just how it is. We can't do anything. When often there are still a lot of things we can do. It's just getting the right resources in to understand what somebody needs. So if there's anything, I want you to know that there are lots of things that we could do for falls and lots of things we can do to help people with dementia function most optimally for as long as possible.
So if we get off this call and you were to say that there are 5 things that you can go out into your house and look for tonight
Hmm.
that you might not even realize are fall or safety risk,
Hmm.
what would those be?
Throw rugs. You might already know that one, but any kind of loose rug. Um, Making sure that closets, stairways, these spaces that we don't always think about light, are well lit. Watching where somebody grabs, reaches for, and making sure there is a good thing there to reach for, something that is meant to be pulled on. Um, some kind of non-skid surface in the tub. That is, I am always surprised by how many people don't have something non-skid in the tub or shower. A lot of the newer showers will have a non-skid texture, but if you don't have something down and it's an older one, putting down a bath mat. That's four, I think. What else would I say? Mm,
I'm putting
mm,
you on the
mhm.
spot.
I know. So, the one other one, well, this is not an easy fix, but sometimes like getting out of a recliner or something, somebody needs some assistance, but there's nowhere to put a grab bar. So a transfer pole, which we didn't talk about, they're like floor to ceiling suspension poles. They can be put anywhere. So somewhere that you can't install a grab bar, but somebody needs something to pull up with. And generally we pull better than we push. So something to pull on can be very helpful. Those are good to look at, a transfer pole.
But that was outstanding.
Yeah.
Thank you. On the
Good.
spot.
Good. I'm so glad.
So thank you so much, Jamie, for this evening.
Yeah.
I wanted everybody to know. Plus, there's lots of thank yous in the chat.
Oh,
So
great. Yes, and I
people,
can see it now that I'm not presenting.
oh, good,
It's
good.
great.
Um, so our next education will be on September 29th, and it will be Understanding Dementia by Allison Lindauer, who is a PhD out of OHSU. And I have it on good authority that she's a great speaker. So I hope everyone is able to attend. And we will have the recording out by the end of the week at least. And I'll be sure to send out all the resources again, just in case anybody didn't receive them. So thank you so much, Jamie, for coming and working a little more after your long day work.
Oh yeah. Yeah. No, my pleasure. I enjoy speaking about both of these topics. So thanks for having me.
Thank you. Bye all.